Thank you very much, chairpersons. I would like to start straight away by telling about the importance of Doppler ultrasound in the evaluation of the venous system. We would like to do the venous Doppler for evaluation of limb swelling, varicose veins, and because of the advent of various interventional techniques like endovascular laser therapy or radio frequency ablation for varicose veins. So because of that, the importance of venous Doppler is increasing. Then of course you need some dialysis patients, you need access, the venous access. Then also you have to use Doppler to identify what is the best access possible in those patients, especially in patients where also the chemoport is required. To evaluate patients for suspected pulmonary embolism, you have to do examination of the venous system, especially the lower limb. And how is this done? Done with a high frequency linear probe, as has been illustrated previously. And sometimes you can use a small sized sector probe, which is called the S12 probe, and can be used especially to interrogate branching points. Of course, if the limbs are highly edematous, then you have to go in for a lower frequency probe, which has a higher penetration. So you may have to use a 2.5 megahertz cardiac probe, or sometimes you can even use a convex probe. Generally, the scanning is performed sequentially from proximal to distal regions. Scanning is performed in various positions, supine, sitting and standing. The leg elevation, diastole compression is used to demonstrate augmentation of proximal flows. And the probe compression is a very important part of the test. It is used to diagnose or exclude a thrombus. The scale at which you are going to examine the color scale is very important. That is the Nyquist limit, and that is generally kept at 15 to 20 centimeters per second for a deep vein examination. But sometimes for examining some of the superficial veins, the recanalizing channels and venous collaterals, you have to go in for a lower scale. The additional maneuvers that you like to do, especially to show the venous incompetence, and this I'll be showing later on, is leg raising, forceful rapid breathing in stable patients. You can do the Valsalva maneuver, the coughing maneuver, abdominal straining, and all this can be performed in the standing position also. So we start with the upper limb veins, and we have got the deep veins and the superficial veins. And the deep veins and the superficial veins, you can see subclavian, the internal jugular vein, you have the innominate vein, subclavian vein, then you have the axillary vein, you have the brachial vein. These are all the deep veins, while the superficial veins are basically the cephalic vein on the lateral aspect and the basilic vein on the medial aspect. And we start from examining the subclavian veins. So you can examine the subclavian veins in the supraclavicularly, or you can interrogate it infraclavicularly. And this is the examination of the jugular and the subclavian veins, the axillary and the proximal brachial veins, distal brachial veins and the forearm veins. And you can have to examine these veins in both the long axis and short axis, because sometimes in the long axis as you try to trace the veins, you tend to lose them, and it's always better that you do it in the short axis position, that is the transverse scanning. And especially if you want to exclude for DVT and you are doing probe compression, it's always better that you are doing it in the transverse plane. Now this is just an example of a subclavian vein, a normal subclavian vein you can see. You are compressing, the vein is getting obliterated, you can see the flow, and sometimes you do not see spontaneous flow. You should not say that there is a DVT or there's a venous block. You should compress, release, then you will show the venous flows better. Compress and release, you will be able to show the venous flows in a much better way. This is an example of a clot in the distal subclavian vein. You have an example of a clot. You can see the flow, and then you can see the venous collaterals going to take the flow around the clot. And this is the clotted axillary vein. You can see that the vein is not getting obliterated on probe compression, and there is no spontaneous flow. When you start with the examination of the lower limb veins, again you have the deep veins and the superficial veins. The deep vein, you start from the external iliac vein below the inguinal ligament, is called the common femoral vein, divides into the profunda femoris and the femoral vein itself, then the popliteal vein, anterior tibial vein, the posterior tibial vein, and the deep veins of the calf. The calf muscles, they are named, and they have the respective deep veins. And then you have the dorsal arch, and then you got the superficial veins, which are basically the long saphenous or the great saphenous vein called GSV, and the short saphenous vein called SSV, and the great saphenous vein joins with the common femoral vein just below the inguinal ligament medially, and you have the short saphenous vein which could join with the popliteal vein. It has other areas where it could drain into. The drainage of the short saphenous system is more variable. Now this is the examination of the common femoral vein, which is, you can see, bifurcating into the femoral vein and the profunda vein. Now when you want to differentiate the superficial veins versus the deep veins, the most important point is that the superficial veins are not accompanied by artery. Many times there is a confusion. You are trying to look for superficial veins, and you get the veins which appear fairly superficial, and you call them the superficial vein, but actually when you see they are accompanied by the artery. Once they are accompanied by the artery, then they are not superficial veins. The deep veins are always accompanied by the artery. The superficial veins are extremely thin-walled, and therefore when you want to examine them for the patency and you want to assess the venous incompetence, it is very important that you apply minimal compression, otherwise you will not see them. You say that you are not seeing the veins, but you are not seeing because you are applying too much of compression. So they get easily obliterated. As compared to the deep veins, these also can get obliterated. Of course, if you apply too much of compression, even the deep veins can get obliterated. But the superficial veins are especially liable to get obliterated. And of course, they will be more superficial, but that is not the major point of differentiation. And whenever you want to examine the superficial vein, you start at the saphenofemoral junction, where the great saphenous vein joins with the common femoral vein just below the inguinal ligament medially from the medial aspect, and you have the three major branches which are going toward the inguinal region, which I'll be just showing it to you, and then you have the three major divisions that are there in the thigh, and the divisions also present in the knee. Now the saphenofemoral junction is guarded by two valves. You have a pre-terminal valve and the terminal valve, and generally in most cases they can be easily seen. They are mostly easy. And this saphenofemoral junction, besides the great saphenous vein draining into the common femoral vein, has got the three major tributaries: the superficial inferior epigastric, the superficial circumflex iliac, and the superficial external pudendal. These are some of the tributaries that are saying that are going towards the inguinal region, and these are the divisions. You have the anterior division, the anterolateral, and the posteromedial. These three major divisions of the great saphenous vein in the thigh, and similarly when it comes into the leg,
you have got the anterior branch, the posterior branch, and the anterolateral branch. And you start with the examination of the iliac veins, and the examination of the great saphenous vein, I told you, just below the inguinal ligament medially, and the examination of the ferruembral vein is at the midline. When you take it at the midline, you will get the ferruembral vein. When you take it medially, you will get the great saphenous vein. And of course, you can examine the distal ferruembral vein close to the knee, and you can examine the popliteal vein from the lateral aspect of the popliteal fossa, and you can take in the short axis the popliteal vein and artery, and when you apply the probe compression, the popliteal vein will get compressed. And you have the examination of the posterior tibial veins. This is examined here, and the examination of the anterior tibial veins and the anterolateral aspect. And this is when you examine the posterior tibial vein from medially, you'll get this is the probe, you'll get the posterior tibial vein and the peroneal vein. First you'll get the posterior tibial, and deeper you'll get the peroneal vein, and when you start from the anterolaterally, you will get the anterior tibial vein and the peroneal vein in that order. You'll get the anterior tibial vein and the peroneal vein when you go anterolaterally. Then you can examine the plantar veins, which are going to the feet, which are the tributaries of the posterior tibial vein. And the veins of the dorsum of the feet will join the anterior tibial veins. And then, of course, you look at the saphenofemoral junction. This is the classical long axis of the saphenofemoral junction. And you can see the valves very clearly, the pre-terminal valve and the terminal valve. This is the valve which is seen, and you are applying the Valsalva strain, and during the Valsalva strain you will not see any flow. When you do the Valsalva release, then you get the blue flow because the flow is coming from the great saphenous vein and joining the saphenofemoral junction and into the common femoral vein. So this is a normal saphenofemoral junction. So then you have the saphenopopliteal junction, where the short saphenous vein is going to join the popliteal vein, but then it does not always join the popliteal vein. It has a more variable drainage, and this junction actually is also guarded by a valve, and the anterior tibial veins join the popliteal vein just distal to the junction. So you get a whole lot of veins at this point. You get the popliteal vein, and then you have the anterior tibial vein, which is joining the popliteal vein, and then you have the short saphenous vein, which is draining into the popliteal vein. But sometimes the short saphenous vein may just give a little tweak to the popliteal vein and may actually go and join the veins inside the superficial veins of the thigh. And then, of course, you have got these veins which I've already alluded to. You have the small saphenous or the short saphenous vein, the superficial, which are, going to join with the popliteal vein. And this is the saphenopopliteal junction. You can see the saphenopopliteal junction very well. Then you have to interrogate the perforators. Now the perforators are direct connections. There can be direct connections between the varicosities and the deep veins. There can be communications between the superficial veins and the deep veins. Communications between the extraaxial channels, where the varicosities are draining into the extraaxial channels and then into the deep veins. The connection to the deep vein is very important to show that it is actually a perforator. To identify it as a perforator, you have to make sure that the connection is to the deep vein. And these are some of the venous system of the lower limb. that we have already seen, and you have the superficial and the deep veins. And the normal sites of the perforators, one has to know that it is in the thighs, in the inguinal region, that you can have in the mid and lower thirds of the thigh, between the mid and lower third of the calf, and between the great saphenous vein and the femoral vein in the thigh, between the great saphenous vein and the profunda vein in the thigh, between the gastrocnemial and the sodial veins, that are the veins of the deep veins of the calf, and the short saphenous veins inside the calf, and between the short saphenous vein and the anterior tibial vein, or between the great saphenous vein and the posterior tibial vein. It can be also between the great saphenous vein and short saphenous vein with the plantar and the anterior tibial veins in the ankle, which are called the malleolar and the inframalleolar perforators. And they are given certain names, that you have the Hunterian perforators in the thigh, the dog perforators in the middle portion of the thigh, then the Boyd perforators around the knee, then the Cocket perforators in the distal leg, and then you have the perforators named at the feet. Now when you want to augment the flows, you can see that when you compress distally, you will get excellent augmentation. Now this sort of augmentation can also take place if there is a partial block of the deep vein. So if you get this augmentation, it does not always exclude a deep vein thrombosis. A partial block, or when there are extensive venous collaterals available, then you will also get this augmentation. And you can see this normal augmentation, so very brisk. Certainly when you compress, there is a brisk augmentation, rapid upstroke, but this is a muted or a damped augmentation indicating a venous block. This is to assess the compressibility, which we have already shown that the osteotibial vein in this case is getting compressed, and you can see that the compression that takes place, this is when there is no compression, and this is when the compression is applied. And in the presence of a venous thrombosis, you see that the veins become incompressible. Now this is an example of a compression being applied normally, the long axis and the short axis both being seen. The veins are getting compressed, means that there is no DVT. This red one is the venous system, and when you compress, it gets obliterated. Now this is a case of a DVT, and in this DVT you can see that the femoral vein on probe compression is not getting compressed, and of course there is no spontaneous flow. So this is acute DVT. Now the signs of deep vein thrombosis therefore are absent or reduced compressibility. This is the most important sign of a deep vein thrombosis. And then of course you can sometimes see a clot of varying echogenicity. In the acute DVT you will not be able to see a clot very well because it is absolutely echolucent. You can get an incomplete color fill-in, or you can get an complete absence of color or flow or spectral Doppler flow, spontaneous, and there is of course impaired or absent augmentation of flow. But having said this, it's important that if you do get a reasonable augmentation, does not always exclude a DVT. Lack of spontaneous flow and increased flow in collateral channels. Now this is an example of a femoral vein DVT, and you can see that the flow is going around the clot, and this of course is showing the clot, little few echoes of the clot inside the vein, and the lumen is larger proximal to the clot as compared to distal to the clot. And of course you can see the tailing of the clot sometimes, and then the flow going through that area. Again, a tailing of the clot giving rise to sometimes appearance of a free floating clot within the vein. Now this is again a lower limb DVT. You can see that the posterior tibial veins are not getting compressed and the flow is seen around the clot. The channels are now forming around the clot and taking the flow, but otherwise the veins are not compressible. Now these are the recanalizing channels. The classical recanalizing channels, you have to go to a low velocity scale of around 10 centimeters or less, and then you can see these flow patterns. These are the recanalizing channels inside the clot. This is the artery, femoral artery, and this is the femoral vein which has clotted, but you can see the recanalizing channels around the clot. This is of course the profunda artery, and these are the recanalizing channels that are seen over here. So when you want to differentiate an acute versus a chronic thrombus, the acute DVT, it is not echogenic at all. So it's anechoic or hypoechoic versus a chronic DVT where it is easily echogenic. During the acute stage, the vein tends to expand, while in the chronic stage, the vein tends to become smaller. Some compression could be possible in the acute DVT because the clot is extremely soft, but however in a chronic DVT it is incompressible. You can get the thrombus tail in the lumen, and the clot could be adherent around the vein in the case of a chronic DVT, and absent or minimal collateral channels in acute DVT and prominent collateral channels in a chronic DVT. Of course, you have to make sure that there are other causes of edematous limbs, and these have to be, these can sometimes cause problems in the diagnosis, and you might wrongly call it a DVT. And sometimes, of course, you get dual veins. The venous system is sometimes paired. So you get two femoral veins, two popliteal veins, two anterior tibial veins, two posterior tibial veins, and if one of them is clotted, the other is patent, and you're quite happy to see a patent vein and say that there is no DVT, but the other vein could be actually clotted. And sometimes it's a partial clot. So you are seeing some flow, you are seeing some augmentation, then you tend to miss it. Segmental calf vein thrombosis, that is, it's not present throughout the longitudinal extent of the calf veins. Then also you will only see part of the veins which are patent and try to extrapolate that the entire venous system of the calf is okay. And similarly, you can get segmental iliac vein blocks. And of course, if the patient is asymptomatic, generally the Doppler tends to be less accurate, possibly because of a less meticulous examination performed at that time. Now, of course, you can have the dual popliteal vein. You can see this popliteal vein is not obliterated. It's not showing any spontaneous flow, but the other popliteal vein next to the artery is showing spontaneous flow. So if you get flow here, does not mean that there is no DVT. There could be additional popliteal vein. There could be a dual popliteal vein. You might miss it. So if you take the results of the Doppler ultrasound, the sensitivity and specificity are very high. Even when you do, if you do it in comparison to venogram, now the venogram is actually getting outdated or already outdated. Now the sensitivity and specificity are extremely high if performed by expert hands, maybe slightly more in the proximal as compared to the calf veins. And of course the addition of color Doppler just adds marginally by 5 to 6%, it improves these results. So the major impact is actually on a B mode ultrasound examination. We look for venous incompetence, and I said you can do various straining maneuvers. The Valsalva by blowing into a sphygmomagnetic cough or a coughing maneuver or an abdominal strain, and it can be performed in the supine or the standing position. The normal response is the complete absence of antegrade venous flow and no backflow. And the venous incompetence is characterized by a prominent retrograde flow, and a very brief flow reversal is seen during the initial stay. That is seen almost in every patient, and less than half a second is considered normal. So that should not be called a venous incompetence. It should be important that when you're applying the probe, you're not compressing the valve itself. So sometimes it is better that if you're getting a venous incompetence, you take the probe a little distally and away from that valve, and again repeat the procedure, and many times you'll see that there is no venous incompetence, meaning that earlier you are actually compressing the valve itself. Now if you do inspiration, expiration forcefully, if you get a reflux during inspiration, it definitely indicates a venous incompetence. Now this is how you ask the patient to do the Valsalva strain by blowing into a sphygmomanometer cuff, and you can see this initial recoil, you can see the initial reflux, this is not equivalent to venous incompetence. This is occupying less than half a second, these are 1 second markers, occupying less than half a second, so this absolutely normal, there is no venous incompetence of the femoral vein. So this is the competent left femoral vein, and this is showing venous incompetence at the great saphenous vein at the junction with the common femoral vein. The saphenofemoral junction is severely incompetent. When you do that compression, you get the retrograde flow. Blue is the antegrade flow, but when you apply the Valsalva strain, the vein expands and you get a red flow. So this is a severe form of venous incompetence that is seen in this patient, and you can see the valves also in this way. The valves are also looking incompetent. For example, this is the right saphenofemoral junction incompetent. You can see the valves, the incompetent valves, and you can see the venous incompetence. And this is the cephalopopliteal venous incompetence. And this is the classical venous incompetence of the saphenofemoral junction, which is seen even on the spectral Doppler. This is the antegrade flow, and this is the incompetent flow. The blue flow, or the below the baseline, is the antegrade flow, and when you ask the patient to do the Valsalva strain, you get the venous incompetence and you get retrograde flow. Now you can also, when you want to scan, you see the ankle varicosities, which are being incompetent and causing the perforators therefore to become incompetent. Thank you.
Thank you very much indeed. That was Dr. K.K. Kapoor from New Delhi with a wonderful presentation, and you have only half a minute for questions. So we keep to the time duration. Half a minute, please, and then we move to the next session.
Any question from the audience? Any query?
Sometimes we see some varicosities in the gluteal region. I mean, I'm unable to correlate with which kind of vessel. You have
That
some.
could be with the perforated channels, or with the superficial branches of the superficial veins over there. So they can see the posteromedial branches of the great saphenous vein, which will be going over there. So it could be related to that. If those branches itself are incompetent, you'll get and you can get the perforators also in those regions.
The treatment in them must be really difficult because...
Well, depends. If you really want to treat them, they're very small, you can just ignore them. But if they are large and causing problems, then obviously you need to add a sclerosing agent, or you need a laser ablation with a microcatheters.
But I think a venous Doppler is one Doppler study which really needs patience. In arterial, you can say that you can finish the study in 15-20 minutes, but a diseased venous Doppler will take a lot of time, and I think a lot of patience is required once you're examining the system. You can really give a lot of good information if you do a good Doppler, the people who do the laser therapy, they really need information on perforators, because if they miss out the perforators, they don't form it, the reoccurrence happens. So I think a lot of coordination is required between the person who's doing the Doppler and the intervention. Sir, thank you for such a lucid presentation. It was excellent learning.